welcome everyone. I am so happy to see first people coming in. We have over 200 signups, maybe even 230, so which is totally understandable because, well, I'm super biased, but it's my favorite session of this webinar series because it's with people that I really look up to and that we find super inspired. And because of people like Erin and Michelle, we were able to start our food pharmacy in Europe, and so that's also just coming to like a full circle now to do a session with them. So thank you first and foremost for those two amazing ladies and everybody that is with us here. So I will take a few minutes to present today's webinar, and we'll do a quick quiz, and then we'll head straight into Erin's work and then Michelle's work, and then we'll have time for Q&A. So I encourage you to use the chat to either introduce yourself, but also to turn on your Q&A section, or just send the questions in the chat, and then we can make sure to answer everybody's curiosities. Alrighty, so this webinar series is part of an Agri-Health outcome payment model project, which is financed by European Union and Province of South Holland. It's a consortium work of 6 different partners, including 2 farming bodies, where we try to connect agriculture, healthcare, and impact financing. So we work with the food is medicine principles to create new markets for organic and regenerative farmers in the Netherlands, and make sure that this future connects farmers into the healthcare system. So this is just a few of the screenshots from our food pharmacy in Rotterdam. We had our first randomized control trial in 2025 with low-income diabetes type 2 patients, where we provided organic local food boxes, trying to prioritize, of course, climate resilient crops as well, together with cooking workshops and health workshops and dietitian visits. And because we got some nice first results, we were able to now continue and scale up our food pharmacy into 3 locations this year. So we are 4 months in out of 6, so 2 more months for over 60 patients. And we had our first 3 months data collection, and we're seeing the first really nice results. So we're really excited to see that, changing dietary patterns does help people. But also, of course, on the community aspect, a lot of patients that we serve are lonely, are people which are of older age, and just being able to be with them every week and check in and ask, how are you doing? I think it's so meaningful both for us and for the patients. And we're also very excited because next month we're going to take our patients to a farm visit, so they will be also able to interact and connect with the farmers that every week provide amazing produce for them. And it was voluntary, but more than half of the participants decided to take a full day of their schedule to see it. And I think that just shows the two-way commitment and curiosity, both from urban to rural and rural to urban, which we're very, very happy about. So if you'd like to learn more about our work, you can check out a website with the QR code here. And yes, as I mentioned, this is a webinar series. So we already went through 3 really nice sessions. We started with Ronit Rindberg from Tufts University, which actually created a paper together both with Erin and with Michelle. So that's super interesting. And she took her time to introduce us what is food as medicine, what is the current state of art in the scientific community. We had a session with Dr. Jenny Godman, which is an ecological medicine doctor working on the crossroad between, the environmental pollution and human health. And then a wonderful, insightful session with Dan Kittredge, which works on the nutrient density and pushing the awareness of consumers towards the quality of the produce. So if you would be interested in watching back those webinars, you can check our YouTube channel, where we posted them directly after those sessions. And we have one final webinar series coming with 2 speakers focusing on innovative finance for agri-health system. So we will have a look at more investment firm that specifically created an agri-health portfolio, trying to really push innovation in this space, and also with Hans, which is a specialist in creating impact bonds and was behind one of the first health impact bond being done in Denmark on diabetes type 2. So that's coming up. And before I will give it to our two wonderful speakers, I will just ask you to join a quick Mentimeter with us. So you can either scan this QR code, or Anne, my colleague, will send you a link to a very few questions, so we can just see where are we as a group in terms of awareness and consciousness of today's topic. So I hope that you can see my presentation well. Alrighty, I will just give you 2-3 minutes for everybody to join, and we will check in of where do you stand within the food pharmacies or produce prescription. Maybe Michelle and Erin will also explain a bit the difference between those terminologies, because even though we had the session about it, it can still sometimes be confusing. So the QR will be still there. So if anybody else will want to join, feel free. And then we start in with, how familiar are you with the food pharmacy produce prescription program? So from not familiar at all, you never heard of it, you just randomly found this webinar, and you thought, oh, that's interesting thing to do on a Tuesday morning or afternoon. Towards, yeah, maybe some of you are already running food pharmacies in different contexts and just wanted to learn from other pioneers in this field, which I think is extremely, extremely useful to share this knowledge with each other. Okay, so we are quite spread. So we do have one person that just randomly found this webinar today and thought it was a good idea to join. But we also have quite a few experts, which I'm very, very happy about, because hopefully you bring some very insightful and very practical questions. And I know that both Michelle and Erin are very open to talk afterwards. So if there's other practitioners that we can connect with, I'm sure they will be happy to do so. Okay, so a question. Should food medicine programs prioritize procuring produce from local and regenerative farms, or rather focus on convenience and scaling? The reason for this question is because when I was connecting with quite a few people in this space, there's always, it seems that there is this tension. Should we go to just supermarkets where everybody can have it across whole US? Or should we really focus on putting money back to the local economies? Yeah, of course, we are biased within this webinar, and we have our answer on one side, and maybe it doesn't have to be either or. Maybe we can, work on scale, but not in terms of replication and local scale. But okay, we can see that most of us lean towards rather local and regenerative procurement, but there's quite a few people also more on the scale and convenient. Very interesting. And do you think that food medicine programs offer a viable income diversification for farmers? In terms of, who purchase their produce, how much of their produce can be purchased, also what kind of type of the produce farmers can sell. Most of us don't know, and I hope that this will change at the end of the webinar. We'll ask the same question to all of you at the end of the webinar, and we'll see if this I don't know will shift hopefully towards the left side of this question. And very fast last question: what would you hope to gain from today's webinar? If you could just leave your thoughts there with us, those are very, very useful, both for the speakers, but also for us to know if we will have future webinar series. Which direction should we? A new world order. Okay. That's a low hanging fruit, a low bar. So more knowledge that we can use here in the US at our primary care offices. Wonderful. I'm very happy to hear that people are coming with such an interest. More challenges and developments in multiple contexts. Some would just like to personally learn more about this topic. Look for some inspiration. Barriers to grow into private healthcare and into long-term initiatives. This is a very good question. Who should lead such initiatives? How to know how to start a project. Learn what success others have seen in terms of local economies development from implementers these programs. How can community kitchens in US help? Share science of food is medicine between nations. Pathways for Dutch companies to create similar projects in other parts of the country. I hope to learn how small and medium scale farms be leveraged not only to supply food as medicine, but to actively disseminate it through direct engagement, education, and agrotourism. How to build infrastructure to help farmers contract with health partners. Create fruitful collaboration in the Benelux. We want to support your food programs with our boxes at EcoMenu. Amazing. Hello, EcoMenu. This is a wonderful initiative from the Netherlands, which also supply local local organic produce. Okay, wonderful. This is very helpful. So thank you so much for everybody that that shared with us their hopes and expectations for today. And well, I'm so excited. I will shut up now and I'm gonna start with Erin. Erin is, yeah, when I first found Erin initiative back in 2022 of her food pharmacy with local organic regenerative produce, I thought, well, it has to be fake because it checked all the boxes that I would say that's the new paradigm, right? It's supporting low income patients, it's supporting patients in needs, it's supporting the farmers, it's doing it right, it's doing it fair, it's doing it local. So it took me a bit of time to realize that Erin is a real person and the initiative is not just something that was made up. And I will let her talk to you further, and maybe you will learn why you thought that I couldn't believe that it's true, what she's doing out there. So, Erin, I stop sharing and you just take us away.
Oh my goodness. Thank you so much. It's so great to be here. Can you see this?
Yes.
Okay, great. Well, I wish I had an hour because there's so many great questions and there's a lot of myths around like scale and local and regenerative and healing people with food. There's lots of things that people don't understand and want to know, and so hopefully I'll hit on a bunch of those, but I got to do it very quickly. So let's see how efficient I can be. So I run a produce prescription program in Oklahoma, which is right above Texas. We have some of the worst health outcomes in the country. We have we have the worst education outcomes. I mean, this is like ground zero for this type of work. And we treat type 2 diabetes with food and education, and we have incredible farmers. We've stimulated local economy. We have saved our state millions and millions of dollars in healthcare costs. And we are expanding and growing and integrating with healthcare, and it is quite a process. And we're kicking up lots of rocks along the way and really helping people and really influencing more of the food as medicine world to see why really investing in farmers is really the key to healing communities and why we're in the place that we're in today. Communities have been utterly destroyed and are extracted from, and that includes our health, our agriculture, and the list goes on and on. And so we're really doing, inevitably, we're healing community through this process. So just to focus, so the baby boomers were our huge influx of population after World War II, and they're all aging right now. 10,000 people turn 65 years old every single day in the United States. And they're on an average of 15 or more prescription drugs per year, and they have at least two or more chronic conditions. So our healthcare system will go bankrupt if we do not make a change in this. And our healthcare system, I started out in a retirement community at 15. This is me at 15 years old, working as a dishwasher and server in a retirement community with 135 55 plus residents. This was my first little inkling into the world of healthcare and what happens with older people. And this is not because they're old. This is because it's a lifetime of not having proper care and nutrition, even wealthy people. But particularly hurts those that are a lot lower income as well. And it's high cost on the system. And, even more so, they can't play with their grandkids. They don't have quality of life. And this isn't right. Um, a society is judged how you treat your children and your elderly. And I don't think we're doing a very good job. By the time I was in my mid 20s, I had worked in all levels of long-term care, and I got a master's in gerontology from the #1 school of gerontology in the world at USC. So I studied the processes of aging and I understood the myths of aging. Well, I was being taught in school that you're not supposed to have a disease and die. That's not like a natural part of the aging process. Like losing some of your hearing, and your taste buds kind of wearing off. Like these are natural parts of aging. And then I started studying like how aging happened around the world. And I went to Italy and I started studying all these things. And I really started seeing that food is this huge ripple effect on someone's quality of life and longevity and community health. And really soon after, I found out how depleted our food is. So if we're supposed to be getting our nutrients from something that's incredibly depleted, how are we going to get well? But if your body is a self-healing house, if it's a self-building, self-healing house, and if it gets everything it needs, it heals itself. Which is the same thing with the soil. And what's happening is the same thing's happening in the soil that's happening to our health. So we're in an absolute chronic disease crisis. We have the largest military in the world. We have military bases in 160 countries. The US is prominently, has a ton of money on health, on military. Everyone knows that about the US. And we spend more on the cost of poor nutrition than we do on our military. There are doctors today saying 3 out of 4 Americans are sick, that 94% of us are not metabolically healthy. We spend lots of money on research on nutrition, but we are really missing the point here. So I was really called back to where I grew up in Oklahoma. I had gone out to Los Angeles, got my master's, learned all this stuff. I connected with Kiss the Ground that was really focused on soil health. I was shocked. I could not unsee that if we could actually restore the soil, we could even increase nutrients in food. And if it has more nutrients, it actually tastes better. And I moved back home and I met this doctor, Dr. Kent Farish, and he said, so he served low income folks, predominantly a Black community, super low income, what's considered in a food desert. So they didn't have access to like a grocery store or healthy produce. I would argue there's not a lot of healthy produce in a grocery store, but more on that later. Didn't have a grocery store for 14 years. They had the highest deaths of type 2 diabetes in our county in this specific area. And what's interesting is his patients were following standard of care. They're doing what the medical industry says to do with diabetes, and they still have diabetes, and they're getting worse, and they're dying. So something's not working. And the doctor was smart. He knew. He said, I want to prescribe food. He saw a study by the Geisinger food pharmacy study, and he was shocked. He was like, with food and some education, we could literally manage, if not reverse, diabetes for type 2. And he said, can you help me do this? And so I raised money to start with 50 patients of his in 2021. And since then, we've expanded dramatically. We have a team of 8 people. We've served over 500 people. We're getting referrals from over 22 primary care doctors in Tulsa. We launched a full-on Spanish program. We are launching a rural program in Southeast Oklahoma this year. So it's like gangbusters. Like it's just, this is working. This is saving us money. We're healing people. So it's a no-brainer. So what is our program? It's a 12-month program. So it's a year long. People get food every other week. So 26 distributions of food with about valued about $50. It's a great variety of fruits and vegetables. Fruits is a little more challenging for us. So it's predominantly vegetables. We do some other dry goods occasionally. And then we require education. So we don't just give people food, we give them correlating recipes, we do hands-on cooking demos, we do movement classes, we do stuff on mental health, we do nutrition classes. I mean, the gamut. And we have a hybrid model so they can come in person or they can do virtual classes and get delivery. So there's some transportation challenges, and so we've made it as accessible as possible. And we source all our food local and regeneratively, and I'll talk a bit more about that. And then quarterly, we're measuring health outcomes. So we have a pre-post survey that we do that measures a lot of other stuff, but quarterly baseline in every quarter. So 5 sets of metrics for A1C, weight, and blood pressure. And that's where we are calculating the healthcare cost savings from the program. So this is just another visual about how the journey works. We get a referral from a doctor. People can also self-refer. Community health workers can refer. We love when we get physicians referring, because when the physician says, this is your prescription for food, they usually adhere, and they're usually, if they're already kind of engaged in the healthcare system, they typically make better patients in our program, but it doesn't mean that that's exclusive. So we screen them for readiness. We want to know, are they going to communicate with us? Do they have a way to store and cook food? Making sure that they're ready to commit to this. My team says it's a 2 hour a month commitment. And we expect them to communicate with the team, to either receive delivery, communicate with us if there's issues, be engaged in classes, and there's accountability. They do have to come to those 5 checkpoints for A1C testing, and be engaged in completing two or more classes per month for the 12-month period. So they get food education for 12 months. We're measuring all this stuff, and then they graduate. And occasionally, there's a small sector of folks that have continued success, that it makes sense with where they are. Maybe they've had a 12 A1C and they drop to a 10, and we can enroll them again and get it down under an 8, which we would want to do to have more control. So sometimes people are re-enrolled and we see continued health savings, and that makes sense for that. So here's some of our team. It's even expanded since. We have folks that have lots of backgrounds. There was a question already in the Q&A. We have a graduate who became an enrollment coordinator. Best marketing decision I ever made. People are trusted in the community. They reflect who the community are. They're relatable. They trust them. This is key. And that's why I believe that community-based organizations are key to this work. They may need help with some like HIPAA security, health insurance type like infrastructure. And we've done something really awesome with the Spanish program. We took a community-based organization that's already trusted in the community, and we basically created the structure and training for them to do what they're already good at doing. And they've actually out-enrolled us in the last 3 months, which just goes to show there's culture differences. But you should trust and support organizations instead of coming in as an outside expert and expecting the community to do what you say. This is our YouTube channel that has all of our cooking classes. We've really leveled up what our content looks like. We really have put emphasis on things being like engaging and interesting. There are so much diabetes education and chronic disease education. It is so stale. People don't like it. They're not going to be engaged with it, and they're not going to feel empowered to change their life. And so we create a culture and an environment that is empowering, that includes accountability, but that they have the tools and they know that this can change their life. This is just a photo of one of our cooking demonstrations. We are doing more hands-on, so they're not just watching in all these classes, but this is one. that they're just showing the chef, and you've got the photo, the TV up there so they can see what he's doing. And I have really pushed the team to do really short stuff because people's attention is so limited nowadays. But I'm amazed all the time that how engaged people are. And it actually, like a 30-minute class ends up being an hour and a half class because people are asking questions and questions and wanting to know what's going on. They bring their nephew, their neighbor. We've improved it so much over the 5 years that it was super low attendance, 5 years ago, right? Now we've got 80, 90% attendance with the way we've tweaked things, and people are so engaged. They love this. We have standing room only in classes. This is a really important thing for things to be engaged. So they go to a class, they go through this line, and they get to have some dignity of choice, like about what they're getting. But essentially, it's two grocery bags. We give them refillable, reusable bags. I forgot to mention we give them a starter kit that was on that patient journey slide, a starter kit with some utensils and a cookbook and some other things as well when they start. So this is our stuff. We've got volunteers and a produce coordinator. This is Jalen on our team. And here's just some pictures of like the beautiful food. Everyone says I've never actually had vegetables till I came in this program, and I have to say it's the same thing for me. So this slide needs to be horribly updated, but this is our first 3 years of data. This is from 311 patients. We purchase food from 27 local farmers, but we have more of a core group, about 7 to 10 farmers that we regularly buy from. Sometimes we're buying like a one-off item from certain farms and stuff like that. Our largest weight loss outlier was 116 pounds, but we've had people lose 7 pounds, 20 pounds, 50 pounds, 70 pounds. Our largest A1C reduction to date has been from, and it still is, from a 13.6 to a 5.4 in 6 months. Our average reduction it's a little lower than this as we've expanded, but it's still about 1 to 2 points per year, which is equivalent to $16,000 to $24,000 of savings per person per year. And it can be the difference between an amputation, kidney failure, stroke, or not. In the first 3 years, we had about a $1.5 million economic impact on our farmers. They've been able to scale, diversify crops, hire people, fix farm trucks. And it's also allowed more local produce for the local community. Nobody was growing certain things, and we commissioned them to grow them, and now other people have access to them, and they've realized these are beneficial crops. We're actually budgeted to spend $1.17 million in local food over the next 3 years, which for certain economic indicators that could be equivalent to almost $3 million in economic impact. And then our first 3 years, we've saved the state $3.9 million roughly based on these A1C reductions. There's lots of figures out there, so that's a whole other conversation. And I would say we've probably saved the state closer to $7 million today. This is, and we don't get any of that back yet. Another conversation to have. But so Carol here, this is one of our stories. She lost 50 pounds. She reduced her A1C by 4.2 points, which was fully remission of type 2 diabetes and went into cancer remission during this program. She can keep up with her grandkids. She's so happy. She's teaching the kids. She gets up and exercises every morning. And this is Jolynn. Jolynn's like our big outlier, but it's super cool to talk about. She was literally on her deathbed, and her doctor prescribed her FreshRx. She reduced her A1C from 12 to a 5.7, and that's full remission. She did that in 8 months, but she had had diabetes for over 10 years. It starts to make you ask certain questions about what we're doing with people. She lost 116 pounds. She was also in an exercise program outside of FreshRx alongside our program. She ended up actually losing 132 pounds. She came off of all her prescription drugs in this time at the same time. So drug reduction is a big deal. That's much harder to measure. And so we're just doing that on surveys and anecdotally. But as we get into working with the health payers more, we'll be able to have a more in-depth evaluation on those things. So here's a picture of her before and after. And so just incredible to watch people transform like this. And of course, the real pharmacists are these farmers. It is a huge benefit for them. Food as medicine has I think, in my opinion, they have the opportunity, but I think we also have the duty and the responsibility to be, we are like a mini institutional buyer. One of the biggest challenges to restoring a local food system, which is extremely important. Like, if we have another like COVID issue or other things like that, trucks stop moving, and in 72 hours, our community could be completely out of food if we don't have trucks coming in. This is a problem. This is why we need to invest in local food. And Food is Medicine has the ability to invest and be, a lot of our farmers would have gone bankrupt without us. Like we can be 10% of their income up to 50 to 90%, which means we also need to diversify their markets. More people need to be buying local food, not only because it's good for the economy, because it's better for you. And I'm going to talk a little bit more about that, but this is something purchasing they can rely on. Um, they can hire people, they can scale, they can grow more things. And that's one of the problems, is that Food is Medicine is not asking, where did our food come from? And this is something we should definitely be asking, because what I said on the Hill a couple weeks ago in DC was, look, you wouldn't prescribe someone a drug 10 milligrams of something if they needed 100 milligrams, right? And you wouldn't do that just because they're poor or because you want it to be easier to scale. You want to prescribe them the right drug. And the amount of nutrient variation is in food is stark. And so I'll be really quick about this, but Dan Kittredge probably talked about nutrient variation in food. And so this is key. So the average fruit or vegetable in a grocery store has traveled 1,500 miles and it loses 10% of its nutrients every single day. The average fruit or vegetable in the grocery store is 14 days old. So there's not much in it when you get it. When you get local food, there's nutrients in it. And spinach can vary 300 to 1, meaning you have to eat the 300 pieces of the least nutrient spinach that you could get in one, which means we're overeating, which means local food's actually cheaper if you're looking at nutrient per pound. So this is something that we really need to look at. Not all food is created equal. And here's another great, if you want to really dive into this, David Montgomery, What Your Food Ate. We are starting to see more and more nutrient density research around really holistic management of the soil. You have to eat 8 oranges today to get the same amount of nutrients that you could have gotten in one 50 years ago. But investing in a system that is not destroying the soil is key. And we have the responsibility to do that for our children. They're going to be inheriting this land that has been destroyed, and we have the responsibility to restore it. And your tongue knows the difference. It's tasty. Everyone remembers their grandma's tomato, or our participants remember their grandma's tomatoes, and they taste way better. So I really believe that farmers are the new healthcare infrastructure. The biggest missing link has been, yes, Susanna. Did you raise your hand? Oh, okay. Um, this is the biggest missing link in healthcare, is the farmer patient doctor relationship that has been utterly destroyed. We're so detached that we don't think local food can scale, that regenerative food can scale. Farmers, particularly in America that have been studied, have 2,000 times more instances of Parkinson's disease. We're losing topsoil. That's where our food is grown. And if it's gone, we're not going to have enough food. So we want to be stimulating a system that can keep feeding us. So this is key. This is the medicine. The farmers are growing medicine. And so great folks out there like Chilpy at Harvard Law School have put out a lot of stuff about how this maximizes outcomes, not only for the community, but for the participants and for the farmers, for local food procurement. And we had a cost benefit analysis done, which means we looked at, does this save us money? So we had an actuary firm look at our first 3 years of data, and they said if we served 5% of people on state Medicaid, so low income folks that are paid for by the state, if we served 5% of them in Oklahoma, we could save the state up to $28.5 million net. So it's like a 5 times ROI, return on investment. And so there's organizations wanting to invest in this as they should. And then May 1st, May 2nd of last year, we passed the Food as Medicine Act of Oklahoma. This directs the state Medicaid or state insurance to start paying for food prescriptions and nutrition counseling. And so I'm working with the state to implement that. And certainly anxious for this to happen and for us to be able to heal more people and pay more farmers. So this is me up in the balcony when they voted. We had a 5 unanimous vote on this bill. It went through 4 committees and the Senate, and then the House voted 76-8. And I was told that it was a band of misfit legislators that vote no on everything that voted no. So basically, everybody agrees on this and it unifies us. So I'll end there and hand it over to Michelle. This is also for people who want to know, and I know this is going to be more applicable to the US, but I think a lot of these resources about how programs works will be very beneficial. You can download this guide. There's kind of a worksheet, and then at the end, there's several resources that are free if you want to figure out how to start a program. But learn from Susanna and Michelle. They know what they're doing, and I'm so inspired that this is happening. The U.S. is not the only game in town, especially when it comes to food pharmacy and regenerative agriculture. People would argue regenerative agriculture is much ahead of the game in other places, and so I'm really excited to also learn from you all. Thank you very much.
Wow, Erin, perfectly 20 minutes. I'm so impressed by your timing. And we'll encourage people, so have a short discussion after Michelle in a second, and then we'll encourage people to just pop in their Q&A, their questions to the Q&A, and we'll finish our session with those. So Michelle, maybe I will share the screen now, and then we will get going with your part of the story, which is also very inspiring and very powerful. So let me just share my screen and we can, yeah, start.
Thank you so much. My name is Michelle Howell. I'm a full-time farmer in Scottsville, Kentucky. Scottsville's near Bowling Green, if you know where that is, and about 45 minutes from Nashville. So that's where we are located. We also operate a food hub, and that's primarily what I'll be talking about today is our food hub that does food as medicine work. I've been working at the intersection of public health and agriculture for a very long time. And I really truly believe it's the #1 way that I have seen that's going to create economic impact for farmers. So I'm very excited to see the interest that we have. I wanted to start for just a moment because I think we spend a lot of time talking about how we're trying to get conventional agriculture to refocus back to local. But I think it's important that we look back and see how our stories, because they're, culturally, no matter what country, and we have this story of how we went from local to begin with to conventional. And so in the top left, my husband, Nathan, he grew up on a traditional tobacco farm in Kentucky. They raised tobacco and beef cattle. On the top right are my great-great-grandmother and great-great-aunt, one county over from where Nathan's family grew up. And they grew most of their own food. Now, of course, lifestyle was very, very difficult doing that. I'm not an advocate for going back to a unnecessarily difficult and hard lifestyle. But I do mention that because a lot of my story and a lot of my food story begins with having experienced hunger. And I find it really interesting that just a couple generations from my great-great-grandmother who grew most of her own food and had access to food, even if she didn't have a lot of financial means, she did have access to food. A couple years or a couple generations later, my mom and I found ourselves in San Diego, California, and we had limited access to food, and I was personally experiencing hunger. So everything I share today comes from a place of trying to be very realistic of the fact of people who are experiencing hunger, and just really be kind of grounded in that reality. It's important to me that I don't ever get too idealistic, that I forget that we don't ever want people to be hungry. That said, I do think that we're in a really exciting place in time where more people are thinking about what they eat, and also thinking about how they feel and how their food makes them feel. And the bottom left, a little bit more of that story. In the community that I lived in as a child, there were a lot of programs similar to what there are now for people who are experiencing hunger. And one day in the classroom, I had someone hand me a kiwi, and she said, anytime you have the opportunity to eat fresh and healthy food, you should, because you're worth it. And her speaking those words to me just greatly impacted me. When I turned 16, I drove up to a peach orchard, and I asked if they were hiring, and I got a job that I stayed in for 9 years. And I was just really, really inspired and excited about this idea that we could grow our own food. So in 2000, this is my husband Nathan and I in the bottom left corner, we were both hired by the University of Kentucky. What happened in the year 2000 was a lot of tobacco farmers started losing their tobacco acreage. So the way that these rural families were sending their kids to college or buying their first vehicle or paying off their property taxes, they were losing that income, and it was really devastating to communities. At the same time, as this was happening, this influx of funding from the tobacco settlement funds that a lot of communities had at the time were put back into the community. And so the goal was to try to encourage tobacco farmers to transition to fruit and vegetable crops. So that was our original role. So this is us. We're on a tobacco farm. We're trying to help them take, this was a field day at a farm. We're trying to help them transition from tobacco to watermelons and cantaloupe. And that's kind of how we got our start. We stayed focused on trying to keep farmers on their land. And then in the bottom right, you can see this is my family. By 2013, we had become full-time farmers ourselves. And you can go to the next slide. Now, I wanted to share this because I think it's really, really important, especially if you're working with farmers or you're thinking about farming yourselves, is there is usually a process and time. Even though my husband had grown up on a farm and I had worked on a farm, the process of from the moment we decided we wanted to become farmers to becoming an actual farmer took a little while. So in 2008, we started growing heirloom tomatoes. We're really passionate about heirloom varieties of produce. We think that's really, really important. But this was just us, me and my family. We were trying to, like the tobacco farmers of my husband's past, just trying to kind of make ends meet, make a little extra money, but do something that kept our hands in the ground. The next year, I became really involved with public health, and primarily with breastfeeding promotion. And I mentioned that because a lot of the efforts that I saw around that time towards breastfeeding promotion are very similar to what we're seeing now, meaning that there was a huge influx of funding from formula companies that were influencing hospitals and people's choices. And there was this idea and this concept that we're going to have to educate people about the importance of breastfeeding, but we're also going to have to be able to give them things that they need. So, for example, breast pumps if they need it for work, giving them breaks at work, giving them access to lactation consultants. So a lot of the same methods that we're looking at now were very, very successful then. And I could even go back and say they were very successful during the smoking cessation programs in the early 2000s. So this idea of combining education with whatever things people need, resources people need to be successful. I also have a picture of me there. I had to have a part-time job, and what I did was I did wedding flowers at the time. And I mentioned that because a lot of times people can see where somebody is, whether that's their food as medicine journey or their full-time farming journey. And a lot of times we have to do what we need to do to make ends meet to be able to get ourselves to the next stage and that next step. And so there were a lot of these things happening at the time. In 2010, one of my daughters started experiencing severe food sensitivities. And this was before you could just go to the grocery store and buy gluten-free or have a wide variety of fruits and vegetables. And so what we did is for an entire year, we did what we called an Eat Local Challenge. And we bought all of our food from local farmers. And this really showed me what was possible, how much was out there. But it was really taking me a lot of time going from farm to farm to farm to buy all this food. And I kept thinking there has to be an easier way. So in 2011, we started Community Farmers Market in Bowling Green with a group of 5 other farmers. That market has continued to be really successful. It's an indoor year-round market. We were the first in the state to start accepting SNAP benefits and WIC and senior nutrition vouchers and a double dollars program. But I wanted to show these pictures because on the left-hand side of the table, I have some heirloom tomatoes, some jars of honey, and some crayons that my kids had melted down into shapes. And then you can see the heirloom tomatoes on the other side. So this is how we started. You know, we didn't start by growing 100 different varieties of fruits and vegetables. We didn't start by, you know, what we did was we engaged with our community and we waited to kind of see what the need was going to be. 2012, we started our first CSA just in our backyard. And then in 2013, my husband's mom passed away from a preventable disease. And she was only in her early 60s. And it really impacted us. And we realized that we wanted, one, to help farmers be successful. And two, we wanted to help people get access to fresh and healthy food. So we quit our full-time jobs at that point and became full-time farmers. And you can see on the left-hand side, that small group of 6 farmers greatly expanded to a hugely successful farmers market. We see very much our investment in the community and our investment in other farmers in the farmers market being what eventually created the opportunity for us to expand now what we do with food as medicine, but it requires us to continue to be part of that community. And so we're still very invested in that farmers market. Okay, next slide. So from 2014 to 2019, you could kind of call these the honeymoon years for us in that things didn't change that much. It was really nice. We really got to focus on becoming really good farmers, growing as much variety as we could, really expanding the amount of fruits and vegetables we were growing year round. We had 3 kind of goals. Our farmers market sales that we were really committed to, our on-farm pickup that we were really, you know, kind of expanding and doing. And then we started piloting food as medicine produce boxes around that time. This is really kind of what we thought we would continue doing. And then, of course, COVID happened. So you can turn to the next slide. Oh, actually, I have one more point to make about that. So one of the things we were doing during this time as well, during that time of really just kind of scaling as much as we could our farm, making sure we had produce available year round, making sure we had lots of variety. We wanted our boxes of food and the food we were selling at the market to include as much variety, as many carbohydrates, as much fruits, as much, kind of innovative things that we're going to help people make meals with. We also were really focused on, the heirloom varieties, growing year round, doing better with cold storage, that post-harvest handling, the quality of the food that we were growing, the diversity of the products, the diversity in the field, moving away from monoculture, helping some of the farmers we work with move away from that. And then really forecasting with farmers to help them to know what should we grow, what varieties should we grow, how much quantity should we grow. And so I'm very thankful that before COVID happened, we had really invested in that time and in our farmers. Now, our farmers aren't necessarily organic or regenerative. I would say if all natural growing was a 1 and conventional was a 10, our farmers fall on that 1 to 2, maybe 3's end of the scale. What I can say is that, we really trust our farmers that as they're able to increase their income, they're able to invest back into their farm and their growing practices get better and better year after year. Okay, next slide. So everybody knows what happened in 2020. In December of 2021, we had really devastating tornadoes in our community. And we had not only a lot of people lost their lives, lost their homes, but in addition to that, lost their electricity was out for a wide variety of a large area of homes. And so people lost everything in their fridge and freezer. And 2 things that happened during that time. First was during COVID. There was a very small window of time when grocery stores were getting empty, restaurants and schools didn't have access to very many fruit and vegetable varieties. And we had farmers who had crops in the field that we could meet that need. And so I remember carrots and lettuce and things like that. We were able to supply local school systems that were doing home delivery through buses to homes. And it was really that kind of that moment in time that you always are afraid might happen, meaning disruption within the food system where local farmers will have to step up and do it. But I'm glad that we did because I feel like us being able to do that, even though it didn't last very long, we really built trust within the community, and they started kind of new people started opening their eyes and realizing, oh, I can see what farmers are capable of. I'm going to reinvest back in them, and they really have done that. Okay, so the next slide. So there's primarily three ways that we've really focused our work since 2020. One is with medically tailored meals. We have an on-farm certified kitchen. This is an area we would really like to expand more into, but it is something that we're capable of doing and what we have done. There is really a need for just quick, easy prepared food for people. Where most of our work right now is with produce prescriptions and medically tailored groceries. And then we also provide direct to consumer delivery, which is really helpful as well. So the next slide. So we support over 30 farmers. We do about 200 home delivered boxes a week. And then we're serving 6 Kentucky counties in our area. Of course, this has happened over a long period of time, and we've slowly been able to scale up that work. But this is kind of this is our goal. We, of course, hope that we'll be able to keep expanding that and growing towards more. But we're particularly focusing on access in rural communities and people who have very limited access to groceries and also limited transportation. Next slide. Okay, here are some of the funding sources that we've had. So starting back in 2011, we had some Kentucky Medicaid companies fund our first double dollar program. And in 2014, they helped us pilot our first food as medicine, kind of produce prescription box. And that has continued to expand. And we're very grateful that we continue to receive funding. These are marketing funds. This is not us billing to Medicaid, but it is funding that they're able to provide us. We have previously had a GusNIP USDA funding for our FreshRx for Moms program, which is a produce prescription for pregnant women that we've now transferred to funding through Community Farm Alliance with actual tobacco settlement funds. The Kentucky Department of Health and Family Services has been a great partner for us. They oftentimes have kind of grants and funding that can be provided directly through health departments. And so that is another source of funding that we have focused on. The Kentucky Department of Agriculture is every state is able to apply for specialty crop funds. And we were able to receive a specialty crop grant that is now providing produce prescriptions for those with diabetes that are referred to by the health department. We have a lot of foundations that are able to provide funding, private companies. Interestingly, we live in the city where the Dollar General store started, but they actually have been a really great partner for us, funding our senior nutrition program boxes. Individual donations, we have individual customers who provide protein, so we can do a protein plus for our produce prescription boxes. These are just individuals that have come together and said, how can we help? And they are funding a dozen eggs to be added on to our produce prescription boxes for people. Of course, private pay consumers, I think making the food as medicine boxes we have available to a private pay consumer who's also, they've been diagnosed with a preventable disease or maybe they're pre-diabetic. We're finding more interest in that and being able to buy a food as medicine box. And then I want to briefly mention the LFPA LFS program. That is a program that we had. And if we want to talk about challenges, of course, I think a constant never-ending pilot program for funding is a challenge. I also have found in 25 years that there will be programs like the local food purchase assistance program that was investing about $400,000 a year into programs like this for us. Came about. It was great when we had it, and then now it's gone. And that happens a lot. I think that means most likely long term, we need to just keep being innovative, but I do find that to be one of the challenges. So next slide. A little bit about our referring clinical nutrition partners. The Kentucky Cabinet for Public Health Diabetes Prevention and Control programs, which are provided by hospitals and health departments. They offer the diabetes self-management and support program classes, and the diabetes prevention program, which is a year-long program that people are enrolled in, and they're getting weekly classes with a dietitian. We're able to provide a fresh food, a produce prescription box delivered to their home every week that they participate in that class. The Kentucky blood pressure program is very similar. We have OBs and midwives that are referring clients to our FreshRx for Moms program, as well as the Health Access Nurturing Development Services, which is called HANDS, which is a once a month in-home program for pregnant women. And then when they have young children, we're able to combine that with our fresh food boxes. And then a huge partner that we started to establish during COVID up through our LFPA funding program was school resource centers and nurses. We found them to be huge advocates in this work, and they can really get food to the people that need it. Okay, next slide. Of course, some of the observed health benefits that most people see is lower A1Cs, lower hypertension, fewer emergency room visits is really why those Kentucky Medicaid companies are interested in funding this work. Increased fruit and vegetable consumption, and increased participation in nutrition programs. A lot of our public health partners, in particular health departments, have a really hard time getting people to sign up for classes and then stay with them long term. And the weekly incentive of that fresh food box makes a huge difference. Just a little bit about what's next, because in thinking about kind of like where we could be growing, how we could be doing better, we really could use tech. One thing I'm really trying to lean into right now is using tech better than I have in the past, improving procurement and inventory management for our farmers, kind of knowing what I have on hand, knowing what farmers are going to be able to provide us in the next week, 2, 3 weeks, maybe 6 months out. Building an innovative marketing campaign and online ordering platform. Really love what like Local Food Marketplace is doing. Just really trying to lean into that and working through that where there's more choice for consumers, more private pay consumers can help lift this work up. And then strengthening our home delivery management, just so we can really focus on that. We're seeing a lot of people, they really need the convenience. This is how they buy their groceries. They get their groceries delivered to their home or want to be able to do that. And so kind of leaning into that while also engaging in that on farm and at market pickup as well. So and that's it. That's my time, right?
Yes, it's perfect. Super interesting. I have few questions, so we also give the listeners and participants to also add a few more questions to a Q&A. So Michelle, I was wondering how closely you're working with the healthcare givers. So like because for example, Erin is you yourself, Erin, with your team, you're facilitating the collection of HB1AC quarterly, and you're trying to hold accountable for this data. And I'm wondering, like, do you work directly? Like, do you have people to come in and they report back to you, or you totally don't have insights rather than just at the end of the program? How does this connection works?
Is that my question
Yes,
with
that's good.
working with public health
Yeah,
partners?
yes, yes.
Yeah, and so of course I'm not a dietitian. I don't necessarily work in public health. I just am a good partner to public health. So it depends on the program. We are working with the University of Kentucky right now to do some data collection. But for people who are enrolled in let's say Wicker Hands, which is that supplement for pregnant women, and or like a diabetes prevention program, diabetes management program, they are having their A1C. Those programs, you're referred by a physician. You have to have a referral from a physician to be a part of the program, and those dietitians are getting access to that client's, with their permission, of course, but they're getting access to that person's weight, their A1C level, their blood pressure, depending on the program that they're a part of. And so all of that data is being collected, but it's, we're running so many different programs. It's kind of, it depends on which one that it is. That's obviously very, very important to funders, but it's also important to the health department in the Kentucky Cabinet for Public Health, who's looking at that to ensure that those programs are successful.
Mm-hmm, mm-hmm. And I was wondering because I have bit of an assumption that when you have an advocate or an educator talking about the quality and how to use different produce, you're able to more diversify. So what we try to work with local produce, and we often have produce that people have never used before. So we try to create recipes for patients, how they can use it or use them in a cooking workshop. I'm wondering if the fact that you do work with food is medicine programs where you have a bit more freedom to kind of provide the patients the products that are naturally to be grown in this season, and you don't have to like stretch too much the soil, if that helps you also with diversification on your farm.
Hmm. Yeah, and one of the things that we try to do is we try to make about 60 to 70% of our box really identifiable foods. So the foods you see when you walk in the grocery store. So lettuce, carrots, berries, apples, sweet potatoes, things that people are going to probably have bought before or will know be fairly easy to figure out how to prepare. Then what we're going to do is we're going to have maybe one new item they've never seen before, that we're going to introduce. And then we're going to be looking at what our farmers need to sell because they have, and we're always looking at quality. It's very important to us that the quality is always really great. But if we have really great quality mustard greens or turnip greens or Swiss chard, we're going to put that in the box because that's what our farmers need to sell that week. And so people know that when they come in, that's, explained to them. But we are trying to make sure that our boxes have a wide variety of different things that people can do different things with: raw, pick up and eat raw, or, roast, or saute, or different cooking methods. But we are trying to also help people kind of come along and understand that they're participating in something that's about the better good of being able to increase what's available within the food system.
And you mentioned that one of the challenges is this constant need of innovation, because a lot of money comes from our pilot studies, which we also experience. That, yeah, it's a lot about just pilots, small scale. And I'm wondering, how is your process of innovation? Is it a potential like university coming to you, or maybe even funders? We also have this experience that maybe funder come into us and say, oh, maybe we would like to do such a program, but for pregnant women. And then we say, okay, then we would need to like redirect all of our resources, educational materials, and all of it to a new target audience. How is this process for you?
Luckily, we've been able to combine a combination of making our programs meet what the funding has, and then also having some funders that are more flexible. So several of our funders are really flexible on what we're able to do with that funding, so we can really make it meet what we see as the need in the community, plus what the farmers need to sell. The other thing that I will say is, having come from LFPA and having to kind of go back to ground zero and work ourselves back up with funding, is sometimes that can be really great, because we had to go back to all of our referring partners, our school service nurses, our health departments, and we had to say, look, our funding's getting ready to be cut, or it's not as stable as it was. And they came back to the drawing board with us. And even though it's had made the work harder, sometimes it can be a benefit to really have more buy-in, and then also creatively kind of work ourselves back in. For example, the private customers who are paying for eggs so we can have a protein add-on to our fruit and vegetable boxes, that came out of the cuts we were seeing to SNAP and Medicaid and some of these programs. So, kind of trying to balance the two. We don't want to always be worried and thinking about where's the funding going to come from, but then kind of seeing the benefit of the community coming together and helping make it work.
And one last, before we will jump into ESO, asking some follow-up questions to Erin, like, I wonder how much is the percentage-wise of the income stream that you have from food is medicine programs versus just sell to directly to customers, just paying for your produce?
Is that question for me too?
That's
You said
the
yeah.
question still.
Okay, yeah. I would say for our farm, 100% of what we grow on our farm, almost like 98%, goes direct to customers. We sell direct to customers that way. For our food hub, which is primarily the food that we're buying from other farmers, I would say 90% of it is programs and 10% of it is private pay. And that's where I think we could increase the private pay there to help supplement. So, for example, if I'm buying 100 bunches of carrots, I think there are 20 people out there that would want to buy a food as medicine box. So I can now buy 120 bunches of carrots from that farmer. That's really kind of the direction that I'm thinking would be the most sustainable way to move forward.
And for that, you need also some digitalization and some better storage system and all of that,
Right.
right? You explained.
Yep. Yeah.
Very interesting. Okay, Erin, I have some follow-up questions to you. Something that really resonated, and I could see Anna was also smiling, is that you hired a participant from last year, and you say that there is like much increased trust and understanding. We had exactly the same experience. We also hired a participant from last year that had a really high decrease of HbA1c and went from 6 medication to one to become like a health ambassador where people can directly talk to her and yeah, just there's so much more trust, I think, because she went through this experience. Can you maybe talk a bit about how like you end up growing your team? Because also you often start with one, no, and then suddenly you have eight, which is obviously comparing to huge companies small, but comparing to NGOs, that's a proper number already of employees working on that in a nonprofit.
Yeah, I mean, I think it's a challenge to find the right people, um, to have a good budget to pay people who are competent. We've done a lot for a lot less. We've had people who make less money than they could make, but they believe in this mission and the growth potential. I've been very lucky to not have to recruit barely at all for employees. Um, People really show up at my doorstep begging to be a part of this. And um, I think that's just because people feel very called to do this. I think people are really being called all over the world to do this work and to be a part of healing their community. And so I'm very fortunate to have found people in the community that I think are trusted. I would like to double down on having more mentees and mentors in the program, like those who have um, graduated, and I'd love to do more of that. And we've been talking a lot about that, at least having them come to our initial like orientations and giving testimony. Deborah in particular, who is the graduate we hired, she's now like advising Tufts University and she's testifying before Congress, and it's like it's so needed to hear the impact. And that actually is very great to do politically. Like people think politicians just want to hear data and stuff, but what I have found in my advocacy work is they really want the stories. They do actually care and they know that other people care about those stories. So hearing directly from both the farmers, the patients, and the doctors, actually all four of us, so Dr. Farish, Deborah, our graduate, one of our regenerative farmers, Kat Robinson, and I all testified together, which was extremely powerful. And I think like Michelle, she's got like a dynamite team with like her being kind of the operator, implementer of food as medicine, her husband being a farmer. Like it's like perfect. We also have on our team a registered nurse. So she can do all the health testing internally because there's been a question about data, which is a huge challenge for community-based organizations. And so you'll find a lot of RNs are becoming farmers. We actually see that. We have three that we know about and talk to, and one that's a great farmer of ours. And so that is also a very interesting sector of finding medical people who get it, who they've been inside the system, they know what's working, what's not working, and that they're very passionate about this. And so we have someone who's an RN who understands how to look at data. She actually got a master's in public health around looking at data and quality improvement on top of being an RN, and now is getting her doctorate. So she could actually de-prescribe meds in our program. So having key people, and she's bilingual, so she was able to really help us get into that Spanish program and can connect really well with that community. And so having a diversity of people with different skills, and it's really like you got to get everybody on your bus, but you also have to find the right seats for these people. And we have definitely shifted and found, and people's skills and their weaknesses have definitely, as you employ them, that kind of is revealed to you. And being a good leader and knowing, okay, they're maybe not great at that, but they're really good at this. Let's move them over here, and finding what really lights people up. And I think that's really key in building a really strong team. It's not perfect. It's a mess, right? But it's a beautiful mess.
Mhm. Very beautiful, nice. And I'm wondering how, because obviously the sustainability and soil health and environmental aspect, it's so prevalent in both of your approaches, right? And for you, Erin, you're a real spokeswoman for soil and soil health. And I think a lot of healthcare professionals are still really lacking the sustainability awareness. And I think that's coming. And in US, we see, Mary Padry and a lot of these amazing people out there trying to push the
Yeah.
connection. But did you have to help to educate people that work with you about the sustainability aspect, or that was within their own interest? Yeah, I'm
Yeah,
curious.
I've definitely educated my team. They have to watch certain movies, like Common Ground. We had a whole meeting where we watched Common Ground. And I actually tested them and had them write, like, to see how they could define regenerative agriculture in their own words. And I was really worried about what their answers were, but I was actually delighted in their response and their ability to describe it in their own way, and actually kept all those little pieces of paper they wrote it on. But we have had to really help providers, health insurance, physicians understand why this is a Cadillac prescription, as I like to say. And as soon as the doctors, I think most people don't know this nutrient variation between local food grown well, and stuff you're getting in the grocery store. I don't think people understand that at all, like broadly. And so the moment you kind of say stuff like some of the statistics I was throwing out, people start connecting this dot again. Like there's a synapse in the brain that's been destroyed that it's like, even for me, someone who is studying aging and chronic disease, like I had no idea soil had anything to do with it. But once you start learning it, even just a little bit, just with some of these movies, and like you could read a paper and you would just start really understanding it. And once you see it, you just can't unsee it. And it's really vital. And I think that some people don't think that regenerative ag isn't scalable. But I think what people focus on scalability, um, I think they're forgetting how we got into this problem to begin with. And there's a scale that's replicatable from a local level and a regional level. And actually, what's interesting is the largest study that's ever been done on regenerative agriculture on 1,700 farm from the Ecodiocese Foundation. They are saying the yields are comparable or even better to those that don't use chemicals. And so I think that as we learn and debunk myths about this, and be able to like look beyond propaganda and corporate interests, we understand what's really good for the community. So we do a lot of education, and I believe that our sourcing component is what is one of the biggest things that we hang our hats on, and it's something we try very hard to be in integrity with. And of course, not everything's perfect, but it's it's something that's extremely important to us. And I think from a sustainability sector, and from really more things that are going to happen. There's been talks like the SEC is going to require um, companies to, offset their carbon emissions, and investing in local farms is like a great way to do that. So I think that more and more people will realize it, and but we're just not at critical mass of an understanding.
I have so many more questions, but I'm privileged to see you also in 3 weeks, and we can then have a chat in person. The same with Michelle. So I will give you the voice to Anne. She has some question, and then we'll do again the Mentimeter to see if your perception have changed after the webinar, and then we'll take the final 10 minutes on the Q&A that is there. So go ahead, Anne.
Yeah, so I think it will be interesting to talk a bit about like which hurdles you overtook in order to really make this work, or what really made the shift, because I think we just are 2 years in and we're trying to create this movement, but we're also stumbling upon lots of like legislation and all this sort of thing. So I was wondering if you could share about the journey that you have gone through and really what changed your way of working. Both of you, but Erin or Michelle.
Okay. The thing that comes to mind is, because I experienced hunger as a child, and because that ends up in Kentucky, particularly being like the center of the conversation, it has been a huge challenge to stay committed to local. There's been so many times where there was just a lot of pressure to scale above what we were able to do with our local farmers. And what I can say now is that decision that there are so many nutrition and food programs available in our communities. Feeding America, there's just tons of programs out there. Making that decision to stay committed to local was the best decision I made, because our farmers are doing by far much more than I ever thought they could be doing. But it was because I stayed loyal to them, kept buying from them, gave them time to, grow and change and evolve, figuring out how to forecast with farmers 6 months a year, a year and a half out. So now when I see what's available and what we're able to, put in our boxes, that's only because we made that commitment to stay loyal to it. And it's really, really hard to do in this work. There's a lot of pressure to maybe do a percentage local or do, part local, but that decision to say our number one priority in this work is we are going to be the provider that stays committed to local, I think is what, and then helped us overcome a lot of the challenges simply because we had remained committed to that.
Okay.
Michelle, good on you for being committed. There is so much, I think society is it's so unhealthy right now, and it makes it much easier to go the more convenient route. And actually, when you go the route of integrity, I was telling my husband last night, it feels like when a dog is like pet against the grain of his hair, like you're going through every day, like being just like it's like constant irritation because you're trying to do things right and there are infinite barriers. And I think you have to come from a place of pure conviction and a commitment to integrity, because at any time there will be plenty of reasons to do it the easy way. And I think that that is where we've really got ourselves in these problems. We have refused to look at the roots of problems, and we keep putting band-aids on problems. I think we have become so obsessed with the sterilization of our food, of our systems. We have become so focused on things being a liability that we have lost the point of helping people and connecting with people. And we've lost ourselves to that. And so just a simple example, we are we were the Tulsa County health champion of because we improved health. We've improved health more than any other program is doing because we're actually solving the complex problem. But in the space in which we were doing our cooking demonstrations, they wouldn't allow any of our participants to cook. So you build $1 million cooking demonstration room that you have hired way too many lawyers, that prevents the point of what the thing was made for. And the fact that we have to navigate stuff like that is the reason why our community is sick. And so we have had to cunningly and patiently work through things that are inherently preventing the point of what things are for. And we have to remind leaders that are totally disconnected. And we've had to navigate that in very creative, relational ways. And it's very frustrating. I think a lot of people don't understand the challenges of farmers. They've never farmed, they've never been on a farm. I've learned a lot. I've never farmed, and I have been humbled many times by learning from farmers what the challenges are. And people do not understand it. They think things come in a plastic bag that come out of nowhere. So I think that when you don't have leadership aligned and you have an unhealthy society that basically is all the incentives are backwards, there's perverse incentives in healthcare. When you're doing something good and changing something, um, there's every barrier you can imagine. And there's lots of evidence of that in history. But you have to know that this work matters. It matters more than, making $500,000 a year. It matters more than any of these things. But you're going to have a lot of patience. And I often get frustrated. And just it's sad that we have to navigate so much stuff just to give people food, fruits and vegetables in the wealthiest country in the world. And so I think that's the biggest mental barrier. And you just have to be prepared for that. And you're going to run into people that will naysay and discourage you. Don't listen to them. Do not listen to them. This is doable. You can do it. Um, and yeah, I just think the more people that are standing up makes it easier for the people that have been doing it for a long time. Like I'm lucky to that Michelle has done this for 10 years. It makes it easier for me. Look, I can point to her. I can point to Dr. Stephen Chin in California. The more that are at the table saying this makes it easier for us all.
Oof, that was powerful. Thank you, Erin, because a lot of times I think when we hit the wall, we say, "Oh, what's next?" No, and yeah, but you always find a way somehow. You always find a way.
Revolution is not easy and it will not be televised.
But you want to say it. Okay, I will quickly go to Mentimeter for just 2 minutes, and then I will ask you a few of the final questions in the remaining time we have. So if you're still there, it's the same link, or if not, then you can see the QR code here or on the link as well in the comments. So we go for the same question again. Yeah, how familiar do you feel now with the topic of produce prescription and food pharmacies? Hopefully, we will see people moving towards the right side of this continuum. Before we had some people who are not familiar at all. So this person either left the call or they have moved to the right, and I hope it's the latter. Okay, so mostly people feel familiar. I think what are my senses, and I wonder if this is also for your and Erin and Michelle, that sometimes we have people that are kind of would like to take the next step. So for them, they would need almost like in-depth food pharmacy program webinar where you really start working with people one-on-one how to create it in their local community. Maybe this is something to think about for the future as well. I think it will be very interesting, but I'm happy that we moved most of the people to the right. Very good. And so the next question was, what do you think? Should it be local regenerative procurement, or should we focus on the scale and convenient, or you still are not certain? And maybe those two are not, they don't have to go against each other, but we see, I think the power of your talk as people working with farmers and being farmers really have moved people towards focusing and prioritizing the local communities and the impact that you can make, which is also often it's even impossible to put it in numbers because there's so much more value and outcomes given to the local economies that you cannot translate everything on the return on investments. And then, do you think that the food pharmacy programs or food medicine programs are a viable income diversification for farmers? And I think talking of Michelle and her hub being 90% around driven by food is medicine, I think that should give us an answer that is 100% a viable model. And of course, I think if combined with commercial customers, that just brings even more value and even more benefits to the local farmers. But the food is medicine component there is really strong in terms of the help that it can provide to the farmers. Okay. Well, that's it. So Anna, I will leave you to the few final questions. I also saw questions in chat as well, so maybe you can jump a bit in between those. And go ahead.
Yeah, I think there are many questions, so maybe we just have to pick some interesting ones. So I don't know, Michelle and Erin, if you have seen some that you really would like to answer, but I think there's one about how is exchange between Tufts nutrition program and practitioners like yourself challenged? Are you building the track? Tufts outlines the future progress, ask for more science. From Dina.
Yes, we are working with Tufts. We have just applied to try to look at the benefits of local food procured food as medicine programs in a larger study. So Tufts is definitely talking to us about that. I hope that answers that question.
Yeah.
The Rockefellers are also invested in a cohort called FIM Plus, which are food as medicine programs that also source local. And then there's a few of us in there that source more like organic regenerative or some percentage. And so we're looking at more of the economic impact. They just came out with the Farm to FIM report I linked in the chat. Oops, sorry about that. And so that shows the economic impact. And then we're working on some nutrient density testing this year with Think Regeneration, another organization in this space. So really excited about some of that. Dina asked about like gluten sensitivity, celiacs. We don't see a lot of that, although I'm sure there's issues with it. And I know from the regenerative ag world that if better wheat quality would be way better. I could eat whole pizzas in Italy and not have a problem. Here I'm in horrible pain. How do you think the growing season compares from Kentucky to Oklahoma? We're probably pretty similar, Michelle. We grow year round. We're kind of
We have what we call strong seasons. You know, we have a
right.
real spring, a real summer, a real fall, and a real winter. So what we call it real, but so
Yeah, so we can grow year round. I think people thought we couldn't. There's still leadership that thinks we don't do produce well. It's just like it's just not true. I love the FQHC question. This is a great model for FQHCs. There's a really large FQHC program that happened in Kansas, which is the state above Oklahoma. Sorry, I don't know where you're from. There were 5 FQHCs that did food as medicine. Actually, one of them sourced local food. The others worked with the food banks, but they had great outcomes. I would use other studies and show that to your leadership, point towards whoever you want. But the Sunflower Foundation in Kansas, you could probably look that up. They did that project. And so FQHCs are doing this all over the place as they transition to more value-based care. This is a model that can absolutely be used. So rural healthcare clinics, FQHCs, great places for these interventions. Let's see.
Then I
I
think
see a
Andy would
question
like to
here.
know
It
more.
says,
Oh,
oh, go
sorry,
ahead.
go for it.
Well, it says you mentioned there's a screening process for program entry. Roughly what proportion of applicants' referrals are screened out, and how do you kind of work with that? Something that we do. I mean, of course, our hardest program to participate in probably is the most successful. It's the one where we're lowering people's A1C. So that program's year long, weekly class. So you have to realize that, you kind of get back what you put in. That said, we do have other programs where you qualify for being pregnant or being over 65. We also deliver to two food pantries that are free to anyone who comes, and they can have access to local food that way. That's probably the lowest input and output. And then, we also have, of course, the SNAP Double Dollars WIC senior program at our farmers market. That's another option for people. So just mentioning that we do try to have a variety of ways for people to get the access, but when we're talking about food as medicine, it is really important to think about that we are trying to help people greatly improve their health. And oftentimes that needs to be combining the food access with the nutrition education.
Yes, thank you for clarifying. And I think there's just one more comment which we are very much struggling with as well, is that in the Netherlands, at least, it's not really allowed for to provide food. So yeah, I think definitely we can learn from you guys with all the waivers you have in order to make that
Yeah, I mean,
thing allowed.
largely healthcare is not covering food. It's not a covered federal benefit yet. There's pilots going on, but a lot of the new healthcare models that are coming out, like our rural health transformation dollars, MAHA Elevate, they all do not cover food. Um,
Mhm.
but our states have many states, actually probably I think over half now, have passed legislation, but the ones that pass legislation that have actually implemented and covered food is a very small amount of people. California, Massachusetts are probably, in North Carolina, probably the largest implementations. And that's why I'm running a federal bill this year. And Michelle and I both testified a couple weeks ago because this would actually federalize food as medicine with some type of priority for local and regenerative. That bill is called Accountable Produce as Medicine. And we're hopeful that that will pass because it's still not a covered benefit.
Mhm.
So it is a challenge. Healthcare has never paid for food before. And so there's lots of people, our lobbyist says the bean counters, they're not looking at the savings, I think, properly. It's because they've just never looked at this before. They don't understand the ripple effect of food on health, unfortunately. And then I wanted to answer this. Yes, there are models for emergency departments. Actually, that's kind of where food prescription started, was medically tailored meals that were prescribed for 90 days upon discharge from the hospital. There's some really great providers of those services, like community servings in Massachusetts. And so there's some other really great lifestyle medicine programs that are happening in hospitals, one here in our local town. And so, yes, and emergencies are usually, unfortunately, when you have people's attention. And so, yes, that's happening quite a bit. Um,
I see where
it,
Mary Beth mentioned that Kentucky is a food as medicine state. So that's something that we're seeing too, is for those that aren't passing legislation, there are a lot of kind of proclamations of support. And so that is an example. So where Kentucky recently made a proclamation that they support food as medicine, really thinking about like hospital procurement and farm to school procurement and prioritizing healthy foods and locally grown foods. So we are seeing there's definitely interest. People, I would say almost everyone now has heard the word food as medicine because it's just been like infiltrated everywhere all of a sudden. But whenever that happens, sometimes things can get really watered down and people don't really understand anymore kind of like what the fundamentals are. So I think that there's going to be a lot of um, need for us to be continuing to kind of explain what food as medicine is and how to actually, especially when you talk about locally sourced. So,
Well, thank you for speed running. Erin, you want to say something before I will go
I'm
ahead?
going to answer the last question in writing real quick.
Perfect. Perfect. You were really good at that throughout I can see you have lots of webinar experience. Um, so thank you for taking the time. I personally learned a lot, and I think it's just so empowering to be talking on a quite deep level. And I know maybe some of the words today have been technical, but I think that's where the real value is, when we can get, not watering down, but we can get really to the real conversation. So Erin and Michelle, thank you so much. I'm so excited that we are going to see each other in Washington in well, basically 2.5 weeks. And maybe I will get to see some of your lobby work in DC. I know that Anna had this experience and it was very powerful for her as well. And thank you so much for everybody that joined. We are going to send the webinar recording later on. And I would say this is just the beginning for this food is medicine global movement for us.
Thank you so much.
Thank you so much. Have a great day.
Mhm.
So.